Hello, everybody. My name is Dr. Tim Fargo. I'm going to be hosting a presentation for you today entitled The Essentials of Scoliosis Detection and Management, and we're going to include some case studies as well. This is all part of a series that is designed to provide information for you about what scoliosis is. You already know that probably as chiropractors, but also looking at how to easily detect it, what some of the nuances are for evaluation, some notes on treatment. Particularly, I'm going to talk about scoliosis bracing, particularly a scoliosis brace product called ScoliBrace. I am a chiropractor, as I said. I've been in practice for 38 years, which is hard to believe. I'm a 1982 graduate of Northwestern, and my practice life has really been spent in trying to help people through a number of different techniques, including in most recent years, a lot of work with chiropractic biophysics. And as an outgrowth of that, I've done a tremendous amount of work with scoliosis detection, correction. So I'll be doing a screen share with you in a moment. We have a PowerPoint that we're going to go through. Unfortunately, this is not live, so you cannot ask me questions, but I will give you some contact information at the end, and you can then, if you choose to, you can contact me anytime. So I am going to do a screen share with you now, and if you just hold on a second, I will see how that goes. And hopefully you should be seeing this screen. And okay, good. So to begin with, I want to make sure that I acknowledge the patients who did allow us to use photographs and case histories from them. Some of them are my patients, and some of them came from Scolicare. Scolicare is a group that I'm aligned with. They're in Sydney, Australia, and they are part of my scoliosis brace team. And they've done a tremendous job of supporting all of us out here in the field. So to begin with, what I want to let you know is that, as the slide says, accurate diagnosis and management of scoliosis is incredibly important. Obviously, if you can detect these curves early, you are going to prevent people from the end stage eventuality of having to have a fusion surgery, as you see pictured. Nobody wants to have it done, and you wouldn't want it, and no patient wants it either, and you really can make a difference. By way of definition, I should let you know, scoliosis is, by definition, using the Cobb method, a lateral curvature of the spine in excess of 10 degrees with axial rotation. So what that means, the latter part, is that you will see the typical rib hump. Of course, that's not as present in the lumbar spine, but you will see actual rotation occur of the musculature and of the spine even in that area. Now, obviously, there are different forms of scoliosis, and it can be quite misleading. On the left, for example, we have an 11-year-old girl who is an adolescent idiopathic case. She has a 50-degree scoliosis. Technically, it's a surgical case. She is a Richter 0, and I'll go over some things about skeletal maturity in a little bit. But the fact that she's a Richter 0 basically is telling us that she is very skeletally immature. She has a deformity at the apex of the curve, and her risk of progression as a consequence of both her age, the curve magnitude, and the deformity is that her progression risk is extremely high. She's not really a suitable candidate for manual therapy or exercise care alone, although those things would be helpful for her. She really needs bracing or surgery, especially being that she's 11 years old. The case in the center is an 80-year-old. She has osteoporosis. She has lateral listhesis, therefore instability. And these are typical features of an adult degenerative scoliosis. Her spine is unstable, and it has degenerative collapse. She really needs scaffolding of one sort, whether it be from the outside, such as a brace, or with surgery. And of course, you have to ask yourself in a case like this, what are the potential issues with surgery? For example, like what are the general surgical complications for an 80-year-old, anesthesia, etc. What about increased mortality, and what impact on her mobility will occur, plus being osteoporotic. That is a limiting factor for surgery because the screws really don't hold very well in that type of bone. The case on the right, this one is a lady with chronic lower back pain. She's middle-aged. She had an adolescent scoliosis, and that is what is now proceeding with her into adulthood. She has a chance of pain relief from traditional treatments such as manipulation, but relief in this case is likely to be temporary, particularly because of the tremendous coronal shift that you see, her postural shift. Bracing could be an option for her, but it would be short-term to realign her posture. Surgery is not really required in a case like this. So really, to summarize, when we talk about scoliosis, it's not a term that describes a single presentation of a patient, and there's really no one-size-fits-all treatment. So what the burden becomes for each of us is to be able to differentiate in each of these cases and look at potential risks and benefits of the various treatments. And so that's what we're going to cover. Now, little quiz here for you with this next one. What we're looking at here is an adolescent idiopathic scoliosis. And what you see here is that this is a 14-degree curve, which is relatively mild. Now, it's still above the threshold where we would consider it a scoliosis, but we have to start asking some questions about this. So think about what questions you would have to ask and answer to determine what the risk of progression is for this person. First of all, she is a girl. She is 13 years old. She's presented with no pain. What is her Risser sign? Well, we can't really see that because the X-ray view that was taken, it was actually for a physical therapist. The X-ray view that was taken cuts off her growth plates, her iliac apophyses, and the therapist who saw her originally classed her as a Risser 5, which means that there's no growth left in her skeleton. She has no family history of scoliosis, and she was told that this wasn't a problem and to come back in 12 months as they were simply going to observe her. So the question is, do you think this case will get worse as this girl grows? Well, here's the answer to that. Let's go here. This is 12 months later. So what did the doctor miss here, or the physical therapist miss? She goes from this 14-degree curve to a 43-degree curve. What was missing was the Risser sign on this patient. She was not a Risser 5 before, she was a Risser 0, which means that she had all of her growth yet to come. The problem was they collimated wrong, and this girl, given her age, the presence of the curve, and her degree of skeletal maturity, is at very high risk of progression. This patient ended up having surgery because the wrong advice was given, and she should have been braced at the beginning rather than waiting a year. So what's the point? Early detection always leads to better outcomes if the correct treatment is given early. Okay? Now, let's talk about some categories of scoliosis, or rather the prevalence of scoliosis. So it's common. Effects are under-recognized, but here we go. In children, we've got 0.3% to 0.5% of the child population. That increases to between 2 to 4% above the age of 18, then 9% in over 40-year-olds, 30+% in over 60-year-olds, and over 50% in 90-year-olds. So one of the key points to be made here is that adults experience scoliosis, and they can do so even without any prior history of it. that should be obvious when you look at the prevalence percentages here, because only 2 to 4% had it at age 18, yet 30+% in over 60-year-olds. What happened? Well, some of these people developed scoliosis when they never had it before. So here's a lady who presented with mild low back pain when she was 50 years old. She had no scoliosis, as you can see at the initial presentation. 5 years later, she has the typical changes associated with adult degenerative scoliosis. So the term officially to classify this is it's adult de novo degenerative scoliosis, like she'd never had it before. So the question that arises here is, did she have, on the film on the left, did she have any obvious biomechanical issues when she was 50 that may have contributed to her adult degenerative scoliosis? The answer is yes. Look at her pelvis. She has an obvious tilt, most likely related to true leg length inequality. So it's really critical. Now here with adults, here we have an older adult. This is a lady who is 70 years plus. She has a pre-existing, we don't know if she has pre-existing or new degenerative scoliosis, but this is her after, what does the date say on it? Yeah, this is July, October, so just over a year. So she progresses to 45 degrees. So this definitely can happen. Now, there's a misconception about symptomatology associated with scoliosis. What is commonly thought is that scoliosis does not cause pain, but what's true is that in adults with scoliosis, they often experience chronic low back pain, especially people, as you see here, with lumbar and thoracolumbar curves. In children, often it's felt that scoliosis is not a problem for children, but mild pain is often associated with scoliosis, particularly around the apex of the curve. Here's a study. This was published in Spine. This was in November of 2016. They conclude that spinal pain is common among patients with adolescent idiopathic scoliosis, and obviously, duh, the greater the deformity, the higher the pain intensity. And so it's something to be aware of, that we can't just assume because it's a child that they're not going to have discomfort associated with their scoliosis. Now, let's talk about the different forms. We have the most common form, if you look at the entire population, the most common form, about 80% of all cases, is idiopathic. By definition, it means a scoliosis of no known cause. Other forms would include congenital. What would that be like? You have a hemivertebrae, for example, or you have a congenital short leg or leg length inequality, which causes pelvic obliquity, and then the pelvis tilts, you get a scoliosis above it, etc. Neuromuscular scoliosis account for 5 to 7%, and then you have a smattering of other ones, including mesenchymal, traumatic, neurofibromatosis, soft tissue contractures, etc. So there are a lot of different forms, but as we said, idiopathic is the most common. What's of critical importance with idiopathic scoliosis is the age of onset. The earlier age of onset, the greater the concern that we have about this patient. In fact, it can be a real red flag, as we'll go over in just a little bit. It can be a real red flag that a person has a scoliosis coming on, prior to age 10. Obviously, curve magnitude and the curve pattern and location. Thoracic curves tend to progress more rapidly than do lumbar curves. I told you I was going to give you a bit of a refresher on the Risser sign. Here you see the iliac apophyses. So this is critical because when we're looking at the maturity of a skeleton, we can use this. There are other signs as well. You have secondary sexual characteristics. You can take x-rays of a person's hand, and actually in the orthopedic arena, that's done more commonly than the Risser sign is. But you can stage or age a skeletal maturity using the Risser sign. You see the ossification occurring from lateral to medial. And the confusion is, I told you about the earlier case that was considered to be a Risser 0 because there was no calcification or ossification shown of the iliac apophysis. They confused it as a Risser 5, where you also don't see any, you don't see the a gap in the apophysis. So this is the confusion, okay? So that's the Risser sign. Now, as I already alluded to, the skeletal maturity, age of skeletal maturity, degree of skeletal maturity is critical. The graph is basically showing us the rate of scoliosis progression alongside spine development. And the bottom line here is the period of maximal risk for girls is 10 to 12 years. And boys, of course, mature later. Many of us never mature, but anyway, from a perspective of scoliosis, the main time of risk or maximal risk is of boys 11 to 13. And what's very important here is that what you should realize is that during this time period of maximal risk, you also have, coincident with that, a period of maximal potential for curve change. Much of this has to do with a principle called the Hooter-Volkmann principle, which I'm going to go over with you in a minute, wherein you have progressive change in spinal curvatures because of the way bone grows or the way bone growth is inhibited under pressure. So, sorry. So here we go. This is the Hooter-Volkmann principle. What you can see is you see a straight spine in A. We see in B a curvature. What should be obvious is that on the concave side of this curvature, you will have greater pressure. And on the convex side of the curvature, or on the outer side of the curvature, you have less pressure. The Hooter-Volkmann principle describes a phenomenon where bone under pressure, growing bone under pressure, grows more slowly. So you can see that a spine under pressure like this will result in more rapid growth on the outside of the curve. And that's what you see pictured in C. What is critical, there's a critical threshold wherein when a curve exceeds 20 degrees, the Hooter-Volkmann principle really takes over and these curves become rapidly progressive. Now I want to take a moment and I want to talk to you about detection, because that's our next thing. Pardon me. We have to be able to take a look at our patients and detect whether they have a scoliosis or not, even if we're not looking at x-rays. So here's, let's go this way. Yeah. Pardon me. So obviously we have to have, we should have level shoulders. When you see shoulders on level, you see a prominent shoulder blade, like you see on the right side. You're going to see a prominent shoulder blade on the side of the convexity. Here we have a visible curve. Hips are uneven. Her hip is high on the right side. Now we talk about the symmetry of the waist. So what you'll see pictured here is her waist is, if you will, indented on the right side and flatter on the left. These are all indications of the potential for a scoliotic curve. Now, if you have one of these in your office, the next thing that you want to do is you can do this visually. You can also do it with an iPhone, but as you see pictured here, there are scoliometers. They're very inexpensive and simple devices. And what you're doing is you're doing an Adams maneuver. And in the thoracic spine, you will run the scoliometer down the spine or up the spine. And when in the thoracic spine, you see an angulation where you've got one side higher than the other, or inclination, greater than 5 degrees, that is a positive finding. in the lumbar spine, anything greater than 4 degrees is a positive finding. Realize that the lumbar spine is usually underestimated, particularly when the person has a short leg on the convex side. In this particular example, if this person were to have a short leg on the left side, that would actually cause a severe underestimation of the magnitude of the curve. Now, what you'll see here as these curves develop is that the posture will become altered according to that pattern. This is pretty obvious. I mean, if you look at the one on the left, what do you think we have here? Well, we have a thoracolumbar scoliosis. On the one on the right, this is a pure right thoracic scoliosis. And the one in the center is a double curve. Now, when you look at these pictures, answer to yourself, which one do you think is worse from a magnitude standpoint? The one on the left is actually 33 degrees. The one on the right is 51 degrees, and the curve in the middle is 72 degrees. Why is this? Well, when you have a double curve, it balances out, and therefore the posture looks even though the curvature inside that posture is much greater. Now, I want to go over some red flags for you. Red flags are obviously things that you need to pay close attention to. If you see primary left thoracic or right lumbar curves, this is all with idiopathic scoliosis, by the way. If you see primary left thoracic or right lumbar curves, you need to be really aware that you have a potential underlying pathology. If you have acute pain, that is also not common in scoliosis when you have younger people. Nighttime pain, obviously. Scoliosis is less common in boys and more often associated with underlying pathology. And as previously mentioned, early onset has a higher risk of pathology and risk of progression. If in doubt on any of these cases, you do need to order MRI, full spine MRI. So speaking of red flags and other forms of scoliosis, on this next film, an MRI, what you're going to see here pictured is a condition called syringomyelia. You can see this is a T2 weighted image, and you see the water density in the middle of the spinal cord. And syringomyelia has something that's often associated with it, and that is pictured here, and that is an Arnold-Chiari malformation where we see the cerebellar tonsils herniating through the foramen magnet. These are obviously really serious complications and are often associated with scoliosis. So that's why it's important to do proper neurological evaluation with your patients and making sure you're ruling out things like this, that you're checking for pathological reflexes, that you're looking for things like cafe au lait spots, you're looking for the existence of other clinical presentations like Marfan's. All of these things can be associated with scoliosis. So definitely something to be aware of. Realize too that scoliosis is flat out a deformity. What you see here is you see this young girl on the left. Obviously, all of these cases, one a young girl, another an older lady, and then a little girl, they have obvious spinal deformity. And I hate to tell you, but no amount of adjusting or exercise will change this. And many of these, unfortunately, end up having to have surgery. Just a little note on this, and I don't mean to give offense to anybody. I understand that many will feel that their particular techniques will correct or prevent progression of scoliosis, but published study in the Spine Society of Australia, which was a literature review, looked at spinal manipulation as a means of correcting or preventing progression of scoliosis, and what they found is that there is not really evidence of chiropractic or spinal manipulation being an effective treatment for stabilizing or correcting scoliosis. Sorry about that. So this, what's really important here to realize is that I'm gonna bridge over into bracing at this point. What I'll tell you here is this was a study, and this was published in the New England Journal of Medicine, that looked at the effect of bracing in adolescents with idiopathic scoliosis. And what they found here was that the success rate was 72% after bracing, and they actually had to stop the trial because it wasn't ethical for them to continue when they started to see the results from bracing. And that's with kiddos. Now with adults, this study, this came out of the Archives of Physical Medicine and Rehabilitation. It looked at the effects of bracing in adults with scoliosis, whether the scoliosis derived from an earlier idiopathic, adolescent idiopathic, or was adult degenerative. And what they found was that bracing was very effective. And what they said is that considering all types of scoliosis, the mean rate of progression, the average, was significantly higher before bracing than after bracing. It went from 1.28 degrees to 0.21 degrees per year. So the person that you see pictured here, this was out of the research study. This was in the published study. What you'll notice here is this person has a right hand curve. It looks to be in the thoracic or lower thoracic spine. Look at the brace they have on her. This is a traditional Boston brace or TLSO brace. And what you can see here is it's simply matching her scoliosis. More on this in just a moment. So, you know, depending on what you see, I'm going to skip over this one. Right there. This chart just goes over all the different treatment options depending upon whether we're talking about adults, adolescents, juvenile infants, the elderly, what the curve ratios are. There are algorithms that can help you make decisions about what kind of treatment is going to be effective. What I will tell you is that when curves reach magnitude of 45 degrees or more in children and adults, surgical intervention should be considered, and they should have at least a surgical consult. Along similar lines, once we're talking about different formulae or algorithms for determining what should be done, this is called a Lonstein-Carlson curve progression graph. And this is something that we use to determine whether or not, for example, a person should simply be observed or should be engaging in various types of physical therapy modalities, scoliosis-specific exercise, or brace, or surgery. And what you can do, you plug in, it's very simple, you plug in the Cobb angle, you plug in the Risser sign, you plug in the person's age, and then you can get a progression factor, which you see pictured at the bottom, and thus determine what their percentage incidence of progression, what the risk of progression is. So this is a super helpful thing. I won't spend a lot of time on it, but what I'll tell you is that when you have curves that are less than 10% in kids, as a general rule, what we're doing is we're simply observing. When curves go into the 10 to 25 degree range, usually what we're talking about, and these are relatively small curves, and we're talking single lumbar or thoracolumbar curves, there's an option to use a nighttime brace. That's not always the case with thoracic curves. When curves exceed the 20 to 30 degree range, we get into a little bit of a different situation where we're going to need more aggressive bracing. And in some of these cases, they'll be able to brace for a relatively short period of time and do so part-time. And then ultimately, once they reach 30 plus degrees, we're into full-time bracing. And what that means is that the adolescent will be in the brace up to 22 hours a day. They sleep in it. They do all of their daily activities in it. And the average adolescent will wear a brace for about 26 months. And they may need a couple braces or more during the course of their treatment because obviously they're growing. And then once we get any bigger than that, thoracic curves in excess of 60 degrees and lumbar curves in excess of 50 generally require surgery. So let's talk a little bit about, let's see, here we are. Let's talk about bracing more particularly. Here's a traditional Boston brace. What you'll notice about this is that the brace is relatively symmetrical from left to right. It creates stabilization. If you talk to orthopedists who are doing this type of work, what they will tell you is that explicitly the intention of the type of braces that they do is to stabilize the curve and keep it from getting worse. There is no stated intention to improve the curve. The braces do not address the three-dimensional aspects of scoliosis, i.e. lateral flexion, translation, and rotation. And as a general rule, they cause the lumbar lordosis to be reduced as they are simply attempting to compress the curve. So that's not something that's really desirable. So the other aspect of this is that when traditional braces, TLSO or Boston braces, are made, the person is put in a plaster cast. The type of brace that gets basically sculpted from that is very much dependent on the skill of the practitioner. Those braces are not effective in larger stiff curves. Cosmetic improvements are moderate because they're not really doing much to correct the curve. And they're difficult for patients to use because oftentimes they are buckling in the back. So let's see what we got here. So this is really critically important. This has to do with the Hooter-Volkmann principle, because if you put a brace on a person and when you put the brace on them, it doesn't cause any change in the curvature, we cannot reasonably expect that spine to straighten to any degree. So the critical thing is that the brace has to actually correct the curve to some degree when you put it on, and I'm talking instantaneously. The bottom line with this is poor bracing leads to poor results. Here you see a couple examples. This is a traditional TLSO brace. Take a look at it. Obviously it's opening in the back. This young lady has a right-handed curve. Look at the brace. It's simply holding the curve in place. Like, you might think I'm kidding about this. I'm not actually kidding. This is what these braces do. Another example coming up. How about this lovely one? Well, this young lady, I mean, this is a pretty fashionable looking brace, but it also does nothing. This type of bracing will do absolutely nothing to correct her curve, and that should be obvious just looking at her. So to give you a contrast, this is traditional brace on the left, and this is what is termed an overcorrective or supercorrective three-dimensional Scoli brace. What you see with this young girl, she has a right curve, and she has a right curve in the thoracic spine. What you see happening here is this brace is creating an overcorrection and translating her and rotating her to the left. So this type of brace has actually a chance of helping this young person. Now I'm going to show you a comparison side by side. Here's a young boy. He has a 32-degree thoracic and 27-degree lumbar curve. In the hospital, they made him a basic TLSO brace, which is common. There is a slight reduction in the top curve, but the bottom curve stays the same. So it doesn't look, you know, it's not rocket science. It doesn't really look very corrective either. So now to show you a contrast, here is, for the same boy, here is a Scoli brace. So in the Scoli brace, he goes from 27 degrees to 3 degrees in the lumbar spine. In the upper area, he goes in the thoracic area, he goes from 21 degrees to 13 degrees. So bottom line on this is all braces aren't created the same. So this is illustrates, this is the same boy now. This is over a longer time period. This is after 3 years, he has maintained his fantastic result. And out of brace, his top curve is 14 degrees, and in the bottom he's 15, and still in the brace 3 years later. So these pictures are taken at the same time, 3 years out of brace and in brace. And you can see here in brace, we've got progressive improvements from the bottom curve being now being 2 degrees and the top curve being 12. So do people hold on to these corrections? Yes, they do. Another illustration of this. Here's a young girl, and what this is showing is that this is a girl who's being treated with Scoliosis, and you see every 3-month interval. Take a look at the left-hand picture, and now take a look at the right-hand picture and see the change that's occurring with her. Here's the same patient. These are x-rays. Sorry, the one is reversed, but she starts out with, and what this is illustrating is what happens over time, because people have contended that, oh, you brace people, but it doesn't hold up over time. You see here that this girl has a 71-degree curve before treatment, and after 2 years and having finished wearing the brace for 6 months, her curve is at 53 degrees. And after 2 years having finished, she's still at 53 degrees. So I'm sorry, the middle one is 6 months out of the brace, and then the right one is 2 years out of the brace, sorry. And let's see, we got another one here. So here's a young lady. She is 13 years old. She was diagnosed with adolescent idiopathic scoliosis. You can see that she has a really significant trunk shift to the left and a positive Adams sign on forward bending. She also has slight anterior sagittal balance issues. Her x-rays show that she has a 33-degree left thoracolumbar curve, and she's between Risser 1 and Risser 2, and because of her immaturity and poor postural balance, she has a really high risk of progression with her scoliosis. A spinal fusion was recommended to her, and she was basically put on a waiting list for surgery. This is her. The parents decided against surgery. They wanted to try the Scoli brace prior to going ahead with surgery, and as you can see at the 1-month in-brace x-ray, there was a dramatic reduction, and she's reduced by 20 degrees down to 13 degrees. It's just spectacular. Here she is. What we're doing here is just showing what I just explained to you. Here's her initial, and here's her in-brace after 1 month. And moving into the future, this is a 3-month follow-up out of brace, and the x-ray was taken with the patient out of the brace for 4 hours. You can see the dramatic improvement. Still, she's at 26 degrees. And even further, here she is. This is a 12-month follow-up out of brace, and this shows even further reduction. And we've got a reduction of 22 degrees down to 11 degrees. And there's even further improvement in the patient's posture, which I think is really, really impressive. So the real bottom line here is there's a lot that you can do for these people. This is just showing her once again out of brace. Now, remember that the actual definition of scoliosis is lateral curves in excess of 10 degrees. We are reaching here a point where this girl doesn't even have scoliosis anymore, which is pretty spectacular. This next one, and we're getting close to the end here, this next one is a 12-year-old girl. She is a Risser 0. She has a 22-degree left lumbar curve. She has no pain, but her parents have great concerns about progression, which they are correct to do. She also has some pretty significant sagittal balance issues. And here she is. Let's see what this one is. This one is a 90-day in-brace x-ray. showing now that she has progressed from, what did we say, 21 degrees to 2.8 degrees, and really a major shift in her whole presentation. Now, this particular patient, she's grown older. She's in her second brace now. I don't have pictures here of her in her second brace, but she's doing tremendously well. And we're looking at really substantially correcting scoliosis in these kids. If this curve that you see pictured on the left hand side had been allowed to progress, we would have ended up with in a very, very serious situation for her. This last one that I'm going to show you is a young lady, not so young. She's 70 years old. She has a 3-year history of progressive postural deterioration. She reported that she really didn't have much of a curve prior to 3 years ago and has no recollection of having had one as a child. The posture that you see pictured is, this is her standing at her very best. She cannot stand any straighter than this. I should mention that with adults, the goal of bracing isn't as much to correct curvatures as it is to prevent progression, improve posture, and reduce pain. The last picture that I'm going to show you, and then I'm going to switch out of screen sharing, hopefully, is her in her brace. Let's go here. Oops, sorry. Mouse. Good. And here she is. So on the left picture, you see her initial posture. Here she is in a brace. And similarly, her looking at her from the front and with the brace. I'm really sorry about the fact that I had to block out her face because the image on the right side, she has the biggest smile you could imagine. And I don't have video here, but her ability to walk was just dramatically improved. So I'm going to come out of screen sharing now. Okay, good. Here we go. All right. So if you haven't already gotten the message that I would give you here is that you as portal of entry doctors have the potential to make a really big impact on people's lives. The first thing is to recognize that scoliosis is quite prevalent in the population, that your early detection of it and directing the patient to the right kind of treatment can make all the difference in the world for them. We have braced people as young as 22 months old. I had a young girl with trisomy 9 mosaicism who had been braced by a local hospital whose name will go unnamed. She had a 45-degree curve when she started the brace. Within 5 months, she had a 60-degree curve. The mother heard about the bracing process that we're doing here and basically begged us to brace this girl. She's now in her second brace. She's doing incredibly well. There's been no progression. This girl had no option. They were going to do a body casting with her, and then every 3 months, they were going to remove the body cast and put a new one on her until she basically reached skeletal maturity. That would have been completely unworkable for this girl. The mother actually said to me, and it's very heartwarming for me, the mother actually said to me, she said, you know, my daughter probably wouldn't be alive without the brace that you did for her. So super cool. And we're treating everybody in between. We have my oldest brace patients are in their 80s, and we're making huge difference in terms of their spinal pain associated with scoliosis. I should mention too, and I didn't really put it here, we also do a kyphosis brace. What you should know about thoracic kyphosis or hyperkyphosis is that the normal thoracic kyphosis is about 44 degrees measured by the posterior tangent method from T1 to T12. When you see a thoracic kyphosis in excess of 60 degrees, your risk of progression as a person ages is extremely high. When it hits 80 degrees, it's virtually 100%. And there are huge correlations between thoracic kyphosis and cardiopulmonary issues, risk of falling, ability to maintain an independent living as a person ages. So it's really critically important. So in summary, like I said, I think it's really important that you recognize and do what you can to help these people, that you direct them properly, whether it be for bracing or surgery or specific types of treatment if you're not aware of them, having them do specific rehab work like Schroth exercises or scoliosis specific exercises can make a really, really big difference for these people. And at this juncture, I want to make sure that you know that I am a resource for you. Now, I didn't create a slide for it, but what I will tell you is that you can contact me. I'm in Edina, Minnesota, and my contact information, you can call us. The name of the clinic is Chiropractic Health and Wellness. We're in Edina, like I said. The phone number is 952-835-6750. Once again, 952-835-6750. You can contact me also via email, and the email address is dr, like doctor, drfargo, that's Fargo, at chwmn.com. M as in Mary, N as in noodle.com. So if you have questions, you can always contact me. What I want to do as part of this symposium is offer any of you the opportunity, if you have any questions or you want me to help you look at x-rays, you can email me. I'm happy to do that as a courtesy. And as part of the symposium that we're doing today, what I'd like to offer you is if you have a patient that you'd really like to be seen, what you can offer them is you can offer them to come to our center and have a full scoliosis evaluation. We normally charge $100 for the eval. We will do it as a courtesy for you, for one of your patients, and it's just something, a gift that you can give to one of your patients. I really appreciate your paying attention, and I apologize that we couldn't be doing this live and being able to answer questions, but like I said, you can contact me at 952-835-6750 or drfargo at chwmn.com, and I'm happy to help you. So I wish you all the best, and please let me know if there's anything that I can do to help you. Thank you very much. Bye-bye.